Good afternoon, doctors. My name is Dr. Kiran. I'm from Shield Medical Affairs. It's my pleasure to invite you today for this very, very important webinar. I would say this is Thoda Hatke because normally in webinars we cover menopause and diverse topics like PCOS and infertility. Today, to speak about a very, very important and interesting topic, which is vaginal birth after cesarean section. We have none other than Dr. Jayantrath sir, and sir is actually sir needs no introduction. Sir has more than 3 decades of rich experience in gynecology. Sir has been a teacher. However, I would like to say a few words about sir. Sir is a consultant obstetrician and gynecology from Cuttack. Sir was the chairperson International Academic Exchange Committee of FOXY between 2007 and 2010. Sir has held many posts earlier. Sir actually was the president Association of Obstetrics and Gynecology of Orissa between 2003 and 2005. Sir is a member of the prestigious SAFOG Executive Council. Sir was also a vice president of FOXY between 2013 and 2014. Sir's key interest areas, all of us know, is menopause, high risk obstetrics, etc., etc. So with this small introduction, I would like to invite sir to give his talk.
Okay, should we start?
Yes, sir. Absolutely, sir.
Am I audible?
Yes, sir. Yes, sir. Very much.
Okay. So good afternoon, friends. Welcome once again to today's afternoon's webinar. And we'll be discussing a topic which is very common and we come across almost daily in our practice. And few issues in modern obstetrics have been as controversial as the management of a woman with prior cesarean delivery. So vaginal birth after cesarean section versus elective repeat cesarean section has been one of the most discussed and debated topics over the last few decades. Now why? There is a concern about global rise in primary cesarean rates, both in developed and developing countries, as well as in the private and public sector. Now, the present evidence suggests that this trend is going to rise exponentially. In 1916, Cragin said, "Once a cesarean, always a cesarean." That was an era when almost everybody had a classical vertical incision on the uterus. 1917, Williams called this an exaggeration. So now the policy is once a cesarean, always a hospital delivery. The low transverse incision on the lower segment of the uterus was introduced by Kerr of the famous Monroe-Kerr duo in 1921. Trial of labor in a case of previous cesarean without recurring indications was accepted worldwide in 1950. 1971, Hellman and Pritchard had a success rate of 30 to 40%. 1978, Merrill and Gibbs got a success rate of 83%. And Pitkin in 1991 called this the most remarkable change in obstetric practice over the last decade. Finally, the American College of ONG in 1988 and subsequently in 2010 as well as 2019 recommended that most women with one previous lower transverse cesarean section should be counseled to attempt labor in a subsequent pregnancy without straightaway going for a repeat cesarean section. Now, if you look at this slide, you'll see the rising trends of cesarean deliveries in the United States from 1989 to 2015. The primary cesarean rates are going up. The total cesarean rates are going up. Whereas VBAC, which showed an initial encouragement till about 1997-98, underwent a decline after that. Probably people were scared, people were apprehensive. There could be so many other things. So this slide is basically emphasized that we should try this graph of VBX should also rise and the graph of total cesarean section should decrease. Now, if you look at the incidence, barring sub-Saharan Africa, cesarean rates have almost quadrupled in the last 3 decades. Latin America and the Caribbean region has one of the highest cesarean rates, 40%, followed by North America, 32.3%. In USA, it was 5.5% in 1970, 24% in 2001, and now it is more than 32%. In United Kingdom also, it was 24% in 2005 and now it is 26.2%. Australia, it's 29.3%. Brazil is a disaster with 55% and a rate of 84% in the private sector. Now, where cesarean section rates are highest and lowest? It's low in Western Africa, Central Africa, Eastern Africa, Southern Africa. It varies between 4 to 6%, a very nice rate. But in North Africa and the Middle East, it's about 29%. In South Asia, 18%. In East Asia and Pacific, it's about 28%. In Latin American and Caribbean, it's a staggering 44%. In Eastern Europe, 27%. In USA, 32%. These are figures from 2018. Now, what is the incidence in India? The overall rate of cesarean in India, as calculated by Foxy in 2016, is 17.2%, which increased from 8.5% in 2005. Even the press has been creating quite a storm in a teacup, and they have made comments like India might soon have the most cesarean births. Cesarean births are nearly 3 times higher in the private sector. Cesarean deliveries have become an epidemic, a record 300% jump in the last decade. We get to see this media reports. They're quite discouraging at times. But on the other hand, you see during 2010 and 16, more than 1/3 of the births were delivered by cesarean section amongst the most well-to-do population and in several states of southern India, such as Andhra Pradesh, Kerala, and Telangana, with rates above 50% in some districts. And why has this incidence increased? Mainly due to 3 factors: repeat cesarean, dystocia, fetal distress, as well as increased safety of surgery, and lastly, increased demand, which is become almost like an epidemic. So ERCS, that is elective repeat cesarean section, contributes to more than 1/3 of this rising trend. And one potential approach to reverse this rising trend is an attempt to reduce the incidence of ERCS and increasing recourse to VBAC. At present, there is a general consensus that in properly selected cases, VBAC can be achieved safely and successfully, provided adequate facilities are available for monitoring both mother and fetus, as well as emergency cesarean section. Now, C-section is a major surgery associated with serious complications and long-term consequences, particularly in multiple cesareans. Vaginal birth following cesarean has also its own risks, particularly uterine rupture. Now, what are the complications of multiple cesarean sections? Wound, uterine infection, placenta previa and accreta, blood transfusion, hysterectomy, injury to bowel and bladder, increased operative time, increased maternal mortality. This number 2 point, placenta previa and accreta, that is also an emerging epidemic, and we come across many cases these days, particularly cases of previous cesarean section. So it has been estimated that one has to do 370 elective C-sections to avoid one case of symptomatic uterine rupture. Now, what are the options for a patient who comes to you for counseling or advice with a previous history of cesarean section? Either you advise her for an elective repeat cesarean section, or you can advise her for a trial of labor after cesarean TOLAC or VBAC, which can either be successful or unsuccessful. Now, there are short and long term risks and benefits, both the mother and the baby, which need to be considered, and decision making is often difficult because the benefits for the mother may come at the price of increased risk for the baby and vice versa. It's a joint decision between the obstetrician and the patient. So it should be individualized and be made after balancing the risks of uterine rupture at vaginal birth against the risk of elective repeat cesarean section. So what are the maternal risks? The most dangerous thing that can happen, or which we are scared of, is ruptured uterus, which is a major cause of short-term but often catastrophic morbidity. Even though the absolute risk is very low, it is been reported to be 39 to 60 per 10,000 by London in 2004, 76 per 10,000 by Guys in 2010, and American College of Obstetricians reports an incidence of very low 21 per 10,000. And this risk of rupture depends on various factors, which we are going to discuss in the following slides. The type of previous scar. Incidence of uterine rupture during VBAC depends on the type of scar during the previous cesarean section. Those patients who had a low transverse incision, the incidence is 20 to 150 per 10,000. That means it's about 0.2 to 1.5%, very low. Patients with a classical cesarean section scar, it spikes up to almost 900 per 10,000. That means 9%. With the T or J-shaped incision, the incidence is 200 per 10,000. And with the previous CS with uterine anomaly also, the increases rises. So the insufficient evidence at present to support the safety of VBAC in women with the previous inverted T or J incision, low vertical uterine incision, or significant uterine wound extension at the time of previous cesarean. That's why all cases during discharge should be mentioned on the discharge ticket whether the incision was T-shaped or J-shaped or whether there was an extension. Often we find these things missing in the discharge ticket. Now with a history of lower uterine segment rupture, the incidence is 60 per 10,000. With a history of upper uterine segment rupture, it is 320 per 10,000. In any case, with a history of rupture, nobody is going to attempt for a VBAC once again. And a case for, it's a very strong case for repeat cesarean section, which should be attempted around 35-36 weeks with antenatal steroid coverage. The factors associated with increased risk of rupture are classical and low vertical scars, increased number of cesareans, short interpregnancy interval, induction of labor, particularly with prostaglandins, obesity, and fetal macrosomia, babies weighing more than 4,000 grams. Some people say even more than 3.5 kgs. Now, the method of closure, these days there is a trend of closing the uterus in one layer, and there are several reports supporting the same. But the evidence is often conflicting. A prior single layer closure carries more than twice the risk of uterine rupture. A continual birth should have a layer closure. This is a report from India in 2014 by late C.V. Hegde, who was the joint editor of our journal. Even the Cochrane database system says the lower uterine segment should be closed in two layers with continuous polyfilament sutures. The risk of rupture in subsequent pregnancy appears to be increased with single layer closure. I personally prefer a double layer closure unless we are doing a tubectomy or time is of essence and the abdomen has to be closed very quickly for some reason or the other. Maternal death. Several studies have shown that there is increased maternal mortality with elective cesarean section compared with vaginal birth. Although the data were conflicting and the differences were statistically significant. But definitely, VBAC has lower maternal deaths. But if you look at the maternal morbidity, that is more in VBAC in comparison to elective repeat cesarean section. The incidence of blood transfusion, endometritis, hysterectomy, thromboembolism, they are all more with VBAC. Risk of maternal morbidity is very little with a successful VBAC. It is highest with a failed VBAC leading to an emergency CS, and it is intermediate with elective repeat cesarean section. So these failed VBAC cases where we do not succeed at trial of labor, they are the bad cases really. It has been seen that the risk of rupture, uterine dehiscence, hysterectomy, blood transfusion, endometritis, just as I said, is much more in unsuccessful planned vaginal birth after cesarean section rather than in successful cases. Those cases where we succeed, the complications are very less. But when we fail in a trial and go in for a section, the complications are more. Long-term complications, planned cesarean delivery is associated with a lower incidence of urinary incontinence, but multiple cesarean deliveries are associated with more difficult and time-consuming surgery, including blood loss and trauma to the bowel and bladder. Neonatal respiratory morbidity, elective cesarean when compared with planned vaginal birth after cesarean increases the risk of transient tachypnea of the newborn and respiratory distress syndrome. The difference is not much, but definitely there is a slight more increased respiratory problems, grunting and all that in those cases who have a cesarean. But again, it depends on at what weeks we do the cesarean. If it is done at 37 weeks, the incidence is 11.4%. At 38.2%, and at 39 weeks, 1.5%. So we must remember that if you are doing elective CS section, the ideal time is after 38 completed weeks. Now, hypoxic ischemic encephalopathy, the incidence of this in planned VBAC compared to ERCS is a little more, particularly if the patient has hypertension. But there is no data on long-term effects. Non-asphyxial neonatal morbidity, complicated vaginal birth may be associated with intracranial hemorrhage. With elective repeat cesarean section, it's almost nil. With operative vaginal birth is 1 in 600 to 900. Whereas if you are doing a cesarean during labor due to failed VBAC, it is increased further to 1 in 900. But there is no association with long-term neurodevelopmental outcome. Now, VBAC has multiple benefits: fewer complications, quicker recovery, less hospital stay, less expensive, psychologically satisfying for the mother, and devoid of the risks associated with cesarean section and anesthesia. Now, the fetal risks, there is a decreased risk of respiratory problems with VBAC, decreased risk of neonatal respiratory morbidity and NICU admissions, decreased incidence of tachypnea in the newborn. Children born vaginally have lower incidence of asthma and pulmonary hypertension when compared to those born in cesarean section. So the factors which are associated with a decreased possibility of success: increased maternal age, obesity, a BMI of more than 30, short stature, maternal diseases like diabetes and hypertension, gestational age of more than 40 weeks, short interpregnancy interval, need for labor induction or augmentation, estimated fetal weight of more than 3.5 kgs. And factors associated with increased possibility of success: history of previous vaginal delivery, history of prior successful VBAC. This is the most specific indicator. When one has had a previous successful VBAC, there are almost 100% chances that she's going to have another successful VBAC. A non-recurring indication for prior CS: greater cervical dilatation, effacement, or rupture of membranes at the time of admission. Now, the indications for cesarean during the prior cesarean birth. This is also a predictor of success. Those with CPD had the lowest success rate. Those with fetal distress, they had the second lowest success rate. And those with non-recurring indications like breech, placenta previa, or herpes, they had a higher success rate. These are the patients where we can try for a VBAC. So the condition of cervical admission, the more advanced the cervical effacement and dilatation at the initial presentation, the higher the rate of success. Patients presenting with a dilatation of 4 cm 4 have around an 86% rate of successful VBAC. Interdelivery interval of less than 19 months between the first and second pregnancies is associated with a decreased rate of success, but no differences in the patients presenting with spontaneous labor. Not only that, an interdelivery interval of 24 months or less is associated with 2 to 3-fold increase in the risk of uterine rupture compared to an interval of more than 2 months. That's precisely why people are advised to give a gap of at least 3 years between after the first cesarean. A short interdelivery interval is also associated with increased risk of morbid adhesion and abruption. Role of ultrasound: thinning of the lower uterine segment is seen in patients with previous years after 27 weeks. 74% women with lower segment thickness of less than 2 mm detected by transvaginal ultrasound develop incomplete rupture 1 week before ERCS. Thus, women with a history of previous years, abdominal pain, ultrasound finding of thinning lower segment with ballooning of membranes into the scar should suggest a diagnosis of uterine dehiscence and be offered immediate cesarean section to prevent a catastrophic complete rupture. But you need a very expert sonologist for this, and I don't think all of us can do it. In fact, I can't. So selection of candidates for VBAC. One, previous prior lower transverse cesarean delivery, a clinically adequate pelvis, no other uterine scar or history of rupture, a physician immediately available throughout active labor, capable of monitoring labor and performing emergency cesarean, availability of anesthesia for emergency cesarean delivery. And the contraindications of trial of labor: previous classical section or inverted T, obstetric indications like placenta previa, abnormal lie of the fetus, previous history of rupture, known CPD, or any other complication of the present pregnancy that warrants urgent delivery. Uterine corrective operations like myomectomy or hysterectomy, non-hospital setting. Harbingers of uterine rupture: acute abdominal pain persisting beyond contractions, a popping sensation, palpation of fetal parts outside the uterus, repetitive or prolonged fetal heart rate deceleration, high presenting part on vaginal examination, vaginal bleeding. Treat any of these as a possible case of uterine rupture and do not neglect it, please. Usually, disorder in the fetal heart rate or disappearance of the fetal heart rate is probably one of the earliest symptoms that we come across. And the signs of frank rupture are abnormal CTG, severe abdominal pain, especially persisting between contractions, scar tenderness, abnormal bleeding, hematuria, cessation of efficient uterine activity, maternal tachycardia, hypotension or shock, loss of station of the presenting part, change in abdominal contour, and inability to pick up the fetal heart rate at the older transducer site. So induction and augmentation of labor, there is a 2 to 3-fold increase in risk of rupture and 1 to 5-fold increase in risk of CS in induced or augmented labor in comparison to spontaneous labor. Oxytocin, if required, should be used very cautiously for augmentation. It is to be used only if uterine activity is clearly inadequate, and great care must be taken to avoid uterine hyperstimulation. In the NICHD study, it was seen that in planned VBAC with induction of labor, the risk of rupture was about 102 per 10,000. With augmentation of labor, it was 87 for 10,000. whereas in spontaneous labor, it was only 36 per 10,000. Sequential use of prostaglandin followed by oxytocin is associated with threefold increased risk of rupture compared with spontaneous labor. Incidence of uterine rupture with prostaglandin inductions were found to be 87 for 10,000 as said earlier, with a higher perinatal rate, but non-prostaglandin inductions, the incidence was not that high. Now, ACOG, RCOG, FOXY, and the Canadian Society, the NICE guidelines, all of them contraindicate the use of prostaglandins for induction of incidence of scar. What does RCOG say for induction of labor in patients with previous cesarean? Augmentation, though not contraindicated, should always be decided by a senior consultant, internet connection to Holonet, after proper obstetric assessment. Oxytocin should be titrated to achieve not more than 3 to 4 contractions every 10 minutes. Serial cervical assessment to record the progress should be done preferably by the same person. And if the cervicometric progress is static for 2 hours, early recourse to emergency cesarean can prevent the rupture of uterus. So, what are the RCOG guidelines for VBAC? Planned VBAC is appropriate for and may be offered to the majority of women with a singleton pregnancy of cephalic presentation at 37 plus weeks who have had a single previous lower segment cesarean with or without a history of previous vaginal birth. It is contraindicated in women with a previous uterine rupture or classical scar and in women who have other absolute contraindications for vaginal delivery. Antenatal counseling should be documented. Final decision for the mode of birth should be agreed upon by the woman and members of the maternity team before the expected planned date of delivery. Informed consent and shared decision making is important. Women should be informed that there is an increased risk of rupture 1 in 200, say around 0.5% in these cases. They should be informed success rate is around 75%. Women should also be informed that previous vaginal delivery, particularly a previous successful VBAC, is the single best predictor of success and is associated with a success rate of almost as high as 90%. And patients should also be advised that planned VBAC should be conducted in a suitably staffed and equipped facility with continuous intrapartum care and monitoring with resources available for immediate cesarean and advanced neonatal resuscitation. A major degree of placenta previa and sometimes even minor or partial placenta previa is a contraindication. Presence of a senior obstetrician is important. Serial cervical assessment to record progress should be preferably done by the same person. If the progress is static for 2 hours, early recourse to emergency cesarean. Augmentation, though not contraindication, should be always decided by a senior consultant. Oxytocin augmentation should be titrated to achieve not more than 3 to 4 contractions per 10 minutes. These are the RCOG guidelines of October 2015. Now, ACOG guidelines, I will not go into the details here. This is more or less the same. I'll just say that they have emphasized misoprostol should not be used for cervical ripening or labor. Epidural anesthesia can be given, and again, those who are at high risk of rupture should be excluded. Induction is an option. External cephalic version for breech presentation is not contraindicated. Now, these are the Society of Obstetricians and Gynecologists of Canada. Again, they have said the more or less the same thing. I'm not going into the details, but they have just added one thing here, that misoprostol should not be used, but dinoprostol gel, a Saviprime gel that we use, can be used with extreme caution. And multiple gestation and diabetes are not absolute contraindications. Women have the right and responsibility to make informed decision about their care in partnership with their healthcare providers. In order to facilitate informed choice, They should be provided with information and support that is evidence-based, culturally appropriate, and tailored to their needs. This is a Journal of Obstetrics in Canada, March 2018. So in certain special situations like preterm labor, the incidence is almost similar in preterm and term births, but the rates of uterine rupture was much lower in preterm births in comparison to term births. But if the first cesarean section was done at an early gestational age, the chances of rupture is more at present, because in the earlier cesarean, the lower segment was probably not well formed and the uterine incision had extended to the contractile portion. Twin gestation, the evidence is limited, and various people have uh, studied this and found a success rate of 75 to 85%. So basically, if the first twin is presenting by vertex and there is no other contraindication, one can give it a trial. Fetal macrosomia, babies weighing more than 4 kg, the success rate is lowered significantly to around 55%. But women with a history of successful vaginal delivery following previous CS have a favorable outcome even if the fetus is macrosomic. Patients with gestational hypertension have a higher failure rate, though the rates of uterine rupture are not increased. In VBAC in singleton, term breech with previous cesarean increases the risk of neonatal morbidity and perinatal mortality and morbidity. And I would personally say elective repeat cesarean section should be done here. Overall maternal mortality was greater in the cesarean group as because it carries the risks of surgery and anesthesia. ECV is an option. Maternal obesity success rate of trial of labor in obese women is low, 68%, than in non-obese women, around 79%. With a BMI of 40 or more, VBAC failure is 39%, and incidence of scar adhesions is also increased to 2.1%. Diabetes mellitus overall success rate in women with diet control GDM with a single fetus and one previous CS is comparable to women without GDM. GDM alone is not an contraindication for VBAC. Maternal obesity and estimated fetal weight should, however, be taken into consideration before taking a decision. So to conclude, in spite of the risks of uterine rupture, which is about 0.5 to 1.1%, VBAC remains a viable option for many patients with a history of CS and a success rate of almost 75%. The decision to undergo a trial of labor should be individualized. Many women bemoan the fact that they have not access to a trial of labor after prior cesarean section. Counseling and informed concern is therefore of paramount importance. The choice between ERCS and VBAC, like every other medical decision, involves a fine balance between risks and benefits. Misopostyl is an absolute no and is contraindicated with rupture risk as high as 5 to 6%. A cautious approach is advisable in cases of multiple pregnancy, fetal macrosomia, multiple previous births, short inter-delivery interval, and induction labor with an unfavorable service. Key to success and a favorable outcome is careful selection of candidates, vigilant maternal and fetal monitoring, avoiding misoprostol, and subsequent use of prostaglandin and oxytocin, low threshold for intervention, availability of all facilities for emergency CS. A partogram is mandatory. There should be a low threshold for emergency CS. Continuous electronic fetal heart monitoring would be advisable in all cases. Postpartum examination of the uterine scar vaginally is not recommended routinely, as those cases who need surgical repair are usually symptomatic. Now, there is place for future research. At present, it is impossible to address fully the risks of VBAC in association with different maternal characteristics to provide women with an individualized risk of rupture and probability of successful VBAC. Thus, it is recommended that hospitals, maternity care providers, and policymakers collaborate on the development of integrated services that could mitigate or even eliminate current barriers to VBAC. Thank you, ladies and gentlemen, for patient hearing. Stay safe.
Sir, thank you so much for a wonderful talk.
Thank you.
Doctor, you can type in the questions to sir on chat.
Okay.
So there is one question from Dr. Alakaran. Can all diabetics be tried for VBAC, sir?
Actually, those who are suffering from type 2 diabetes mellitus prior to getting pregnant, they are not very good cases for VBAC. But a well-controlled GDM can be given a trial of labor. Okay.
Any questions to sir, doctors?
I think everybody wants to do a cesarean. Nobody wants to go in for VBAC.
Sir, there is a question from Dr. Indira, sir. Is there any difference between single layer or double layer closure?
As I said, many people are practicing single layer closure these days, and the evidence is rather conflicting. But there are so many reports to say that increased incidence of rupture with single layer closure. So ideally, a double layer closure is better until we have very robust evidence that single layer is as good as double layer. At the present, probably double layer would be suitable, unless you're doing a tubectomy.
Thank you, sir. Sir, the next question is from Dr. Kashish. Can you shed some light on the fluid management during trial of labor?
The fluid management.
Yes, sir.
Well, the fluid management during trial of labor, we must always keep in mind that these cases may not succeed always, and we may need an emergency cesarean section. So it is rather ideal not to give them too much of food, and I think slight small amounts of oral fluids can be given, but the major amount should be substituted by intravenous fluids, by Ringer's lactate and dextrose, and better not to give her much orally. I would not say nothing by mouth, but we can give sips of water and all, electrol and all that. I don't think there are any more questions today, aren't there?
Yes, sir. Any more questions to sir, doctors? Any comments? Would you like to share your experience with sir?
Yes, I would be like to. I'd like to hear some experiences from our audience also. They are all experts, you know. They can give some opinion. How many really going for this? Like if this question is asked to me, I would say those who are working in teaching hospitals, they must at least keep this in mind that a vaginal birth can be attempted because there are enough residents and postgraduates who can take care of the patient almost on a one-to-one basis with continuous surveillance. But those working in maybe rural setups or small nursing homes, and where immediately you may not get an anesthetist or a neonatologist, I think those are the places where a cesarean is better. But those in teaching hospitals should always give this option of VBAC to their patients.
Thank you, sir. Sir, there's one more question from Dr. Kashish. Sir, what is your opinion about the use of vacuum in trial of labor?
Yes, we can use it to cut down the second stage. I think whenever previous cesarean is delivering, we always try to cut down the second stage of labor. Earlier, we used to give a low outlet forceps many times, but these days we have forgotten the forceps and we can give a vacuum. In fact, we do sometimes because the second stage has to be cut down. Digital exploration.
So with no further questions, sir, can we wind up the session or?
Yeah,
Hi, sir, there is one question. There is one question from Dr. Malini. Sir, in case of IUFD with previous cesarean, how do we manage? What is the place of induction there?
This is a very interesting and difficult question. Those who come in early pregnancy, let's say even in the second trimester, those cases normally we use mifepristone followed by Foley's catheter, and even misoprostol can be used. But a term pregnancy with IUFD, I think we leave her by herself to go into spontaneous labor, or at best ripen the cervix with uh, Foley's catheter, and then allow her to go in, because straightaway induction would not be ideal. And going in for a cesarean section also, one would hesitate a bit. But if necessary, one can do it because the mother's life is important there. That's a difficult decision which has to be, decided on the spot. But like if somebody comes with a congenital anomaly at 20 weeks, we are terminating them, aren't we? With mifepristone followed by misoprostol. It's that way.
Sir, Dr. Malini also comments, we have been using Foley's for induction, but the risk of scar rupture is high.
With Foley's alone?
Yes, that's what she says.
So I can't comment.
She's doing Foley's alone. She says the risk of scar rupture is high in her experience.
Okay, I can't answer that question, but I don't know why it should happen. If with Foley's alone, there should not be an increased incidence of rupture. But this is interesting. I mean, she could publish a paper on that. We'd like to know the incidence. But personally, I have no experience on that. Neither have I come across any reports. In fact, Foley's is recommended in these cases.
So the next question is also from Dr. Alka. What would cause you to recommend a cesarean section during labor?
During labor means in the case of previous cesarean birth.
Yes, sir.
Yes, well, first thing is if there is non-progress, like I said, if there is cervicometric progress is static, or there is fetal distress, or there are signs of rupture, the threshold should be rather low. The same precautions that the same conditions in a case of primigravida or a multigravida with no history of cesareans, we can wait and see. But in a previous cesarean, our threshold should be low. And any case where we find the progress is not up to mark, or there is fetal distress or something, it's better to go ahead for a cesarean.
Sir, The question again is from Dr. Alka. What anesthesia would you recommend?
Well, if the patient is delivering vaginally, epidural can be given if the facilities are available, continuous epidural or whatever. And if you are talking of a cesarean section, then obviously regional anesthesia like a spinal is always advisable. And there was some question at a time whether if you are giving epidural, the patient can properly push or not. But I think epidural is safe and has been tried also in many cases.
Thank you, sir. Sir, what type of fetal monitoring would you recommend? Would you usually recommend for VBAC patients?
A continuous CTG, continuous fetal monitoring is always good, but then it's not available everywhere. But ideally, electronic fetal monitoring is good in these cases, advisable.
Sir, there's a question from Dr. Kashish. Can you comment on scar thickness early in pregnancy on ultrasound?
Personally, I can't, but I think maybe an expert sonologist can. They say around 27 weeks or so it starts to thin out. So I don't know if there are some papers I've come across that scar thickness can be by detected the thickness or thinness of it by sonohysterography in the non-pregnant state, you know. But in early pregnancy, I don't know if it can be detected, so it can give us a very good idea whether we should go ahead for a VBAC or not.
Thank you, sir. So the next question is from Dr. Indira. Would you like to share any experience about opening the abdomen after delivery due to rupture?
Opening the abdomen after delivery due to rupture. No, but in the initial days when misoprostol had just come in, I had one case who had rupture when misoprostol was used, though it was in a very low dose. But I have no experience of opening up somebody after delivery for rupture. When a rupture should be diagnosed ideally immediately, and after delivery I have not come across. In fact, it is not advised that one must digitally explore the scar after delivery also, because if it was symptomatic, then there would be some signs, you know. Everybody should not be explored digitally. Personally, I've never had to open up somebody after a VBAC.
Thank you, sir. Any more questions to sir, doctors? One minute, sir. Chitrakala, can you unmute the participants in case anybody wants to discuss anything with sir?
Sure, I will unmute. Now the participants can unmute themselves, the doctors can unmute themselves, and if any questions they can ask Dr. Jayendra.
She unmuted all so that if anybody wants to ask, they can ask
verbally. Okay. This is a question from
Dr. Malini KV.
Okay. They had experience of opening abdomen after VBAC following suprapubic hematoma. Is it?
Yes,
Hello?
sir. Yes, sir. Yes, sir.
Okay. Then what happened to the case? We'd like to know. Could we get her on the...
Yeah, Dr. Malini, you can unmute yourself and discuss with sir. So she comments patient did well.
Okay. Where exactly was the hematoma?
Lower segment scar ruptured.
Lower segment scar ruptured. Okay. Then obviously one has to open up. There is no way out. There is no way out. How was it diagnosed after delivery of the baby?
Yes.
Okay. Fine. So I must say well done if you opened her up.
Remove clots and resutured.
Okay. You removed the clots and resutured. The clots are in the abdominal cavity.
Yes.
Good. Well, I think that is the standard procedure what one has to go through. Any other question or should we wind up?
Sir,
Yes.
rupture uterus diagnosed with a head in the outlet. How do you proceed? You take the baby out and then proceed, or you directly do a laparotomy?
No, I think we do a laparotomy and pull the baby out from the abdomen. Because by pulling the baby out through the vagina, I think we may increase that rupture, you know.
Yeah.
If we are sure she has ruptured,
Yeah.
there's no point in
Yeah,
pulling on
there
the
is a
baby
supra
from.
baby. Yeah. Because we had an experience like that, and we removed the baby first, and it was really a mess on opening the case. Yeah.
And maybe
Yeah.
we'll increase the size of the rupture, isn't it?
Yeah. Oh, it's increased. Okay. Thank you, sir.
Thank you. So I think it's 3 o'clock. It's time to close. Am I right?
Yes, sir. Yes, sir.
Okay.
So I would like to thank sir first for giving a beautiful talk. I think we all enjoyed the lecture, and sir actually covers a great balance of science as well as practical experience. So on behalf of the audience, I would like to thank you, sir. And on behalf of Shield Healthcare also, thank you for sparing your time and giving us this lecture. And I would like to thank the audience also. Thank you, sir.
Thank you so much for organizing this webinar. And I must thank the audience for their participation, for the interactive participation.
Thank you, Dr. Jayantraj sir. I am Kumar speaking on behalf of Shield. Appreciate your esteemed presence, valuable time, and that of the audience too today.
So am I very grateful for organizing this. It's nice for me to talk also, you know. My own knowledge was also sort of refreshed, you know.
Yes, sir. And we also seek your permission to share your valuable expertise with as many participants as we can on different topics based on their needs, sir.
Okay. Thank you so much.
Appreciate that, sir. Thank you.
Thank you.
It is good, but
All good.
ഇപ്പൊ നോർമൽ ആയിട്ട് BP 114 പോട്ടമ്മ